Okay, this was a study was done within the context of the routine evaluation of the Dutch breast cancer screening program. So, as Emile Rutgers told, this issue is about screening today. So I think it's good to just to have a look to some basics of screening. What do we want with breast cancer screening is the reduction of breast cancer mortality. The method is the early detection of breast cancer, but it's not the aim to find as much as breast cancer. What we want to do is to find the right breast cancers. It's a secondary prevention that's important. The Germans have a nice term for it. That's Früherkennungsprogramm. I think that's what it is. We aim at the collective benefit. That's important because it urges us to have a good look to the balance between benefits and harms. Benefits in terms of lower mortality, life years gained, but on the other hand you have a lot of women that are bothered with anxiety. Some have a false positive result, some will even be over-detected. Preferably such a program should be evidence-based, but the point is that in women older than or 70 and older, we have no trial evidence for that mammography screening is working. On the other hand, if mammography screening is working in women aged probably 68, why shouldn't it work in women aged 72 or 74 or probably even 76? Model simulation confirmed this, and that under optimal conditions it could probably even be possible to screen up to the age of 80 years. But this depends how breast cancer, especially tumor growth, is behaving. Anyway, if you are screening at higher ages, then the harms will increase, and this means that the balance becomes less favorable. Just why is tumor growth so important? If tumor growth becomes slower and slower with age, then you will have more harms. Most important is overdiagnosis. That means if we find a lot of breast cancers, a lot of them would never have surfaced in lifetime of the women. So this is a poor overdiagnosis. We will gain less life years, and the life years gained is the main benefit of the screening program. And women would have to live longer with the knowledge of having a breast cancer. This will affect negatively quality of life. In 1998, the Dutch breast cancer program was extended to women aged 70 to 75 years. And I just show you with this slide, and you have not to read both sides, that there is no difference in invitation and screening policy. It's a 2-yearly invitation for a free mammogram in one of the dedicated screening units. All mammograms are double-read, and all women are informed about the result by letter. If there is any abnormality, suspicion, lesion, then women are referred to the GP. Main results at the left is what I'm going to present in the session, but just summarizing at the right, you will find we had a high participation in the period 98 to 2006. That's 72% for the women 70 to 75 years. The most important we found was that in older women you find more cancers, but the cancers are prognostically less severe. That's in fact an important finding. Just some other results. We had a decrease of mastectomies within this age group of 20% in only 5 years. So, in other words, an increase in breast conserving surgical treatment. And skin examinations seems not to be more expensive in elderly women. This was just an illustration for the participation. Sorry. Have a look to this line. women of 70, 74 years started with 62%, and now they are increased to 78%, so there's not much difference with younger women in participation. Breast cancer mortality for the age group 75 to 79 years. Why this? From experience we know that it takes some years to have a visible effect on breast cancer mortality, so usually you can better evaluate the breast cancer mortality 5 years later in a 5 years older age group. Then we that's another pointer. Sorry. Then we see that in the pre-screening phase, up to 98, breast cancer mortality was more or less stable. It was 166 per 100,000 women, and then we have a sharp drop to 117 per 100,000. That's a drop of approximately 30%. When we would not have a screening program, then we estimate this black dotted line. We would have approximately this breast cancer mortality at the moment, and this is more or less the same drop of 29%. And when we would only screen, so as originally intended, women of 50 to 69 years, this is the red line here, then you see with the 70 plus women, the breast cancer mortality dropped much more. What can we conclude from this? Mammography screening is effective in women up to 75 years, and including 75 years in our case, and the extension of the program was justified. Some other remark, we still have indication that tumor growth becomes slower with age. So this means that at the moment we still think that 75 years is an appropriate upper age limit for such a program. But we have to analyze this in combination with model simulation to find a definite answer. Thank you.